my own patient x-rays, my own patient photographs, and explaining the importance of cephalometrics. And in between, I'll be answering not 5 MCQs, guys. I'll be answering 10 MCQs as a bonus tonight. If you listen to me carefully, quickly. Cephalometrics. Now you have a patient in front of you. Father and mother sitting in front of you with the son, 10-year-old, saying, sir, my son's teeth coming forward. What do I do? Too much forward, doctor. What to do? Now you take pictures. You take a different picture. Look at this picture. Guys, come to the chat box. Tell me the overjet. What do you think is the overjet according to this photograph? Anybody interested in chatting? No interest? Just want to listen only? Anybody interested in chatting? Come to the chat box and type in what is the overjet. I am assuming you know what is overjet. Overjet is the horizontal overlap, not the vertical. The horizontal overlap. What is a normal overjet? 2 to 4 millimeter. How much is this overjet here? Can somebody type in the chat box? Just to satisfy me, please type something here. Sarah, please do something. Yeah, oh, wow. 8 to 10, 8 to 10, 8, 7. Perfect. Yeah, this particular kid has an overjet of, believe me, 13.5 millimeter. That's a huge overjet. So the moment the patient is in front of you, with the father and mother sitting in front of you, with a huge overjets, are my son's teeth coming forward. Teeth coming forward. Now, let's look at. So, is his maxillary incisors really forward? How do you know? How do you know whether the maxillary incisor is really forward? You know how to know that? Take a lateral ceph. Take a lateral ceph. In the lateral ceph, find out. Now look at my mouse point here. Find out the incisal tip and the root tip. Incisal tip and the root tip, and draw a line up there. Draw a line up there. Is it very difficult, guys? Forget cephalometrics, please. Forget cephalometrics for some time and listen to me. Listen to me. Draw a line from the tip of the central incisor to the root of the central incisor and extend the line all the way up. And now draw another line, which is something called as sella nasion. What is sella? Look at my mouse here. Sella is supposed to be the midpoint of the pituitary fossa. Midpoint of the pituitary fossa. And then nasion is the place where the frontal bone meets with the nasal bone. This point here. Draw a line. Draw a line. Draw a line. Find out this angle. Guys, can somebody come to the chat box and tell me what is a normal value? Let me tell you, there is a value which is considered as normal for the central incisor of a human being. Dr. Shivani Gupta is saying that my audio is not clear. George or anybody in Team Focus, please clarify. Am I okay? I'm literally
audio is clear. It's very audible. Like probably it should be the problem with the
maybe her own audio issue, I guess. Because I'm literally shouting here. That much I know. Why my wife just signaled, come down, come down. So I know I'm shouting. Am I okay?
Yeah, you
all right.
We can see you shouting.
All right, I know that. Okay, so can somebody come to that normal value? Human being, sella nasion, pituitary fossa to the nasion line and the central incisor, there is a value which is considered as normal for human beings. And that normal value is what you have to know here. This is called upper incisor to sella nasion. Upper incisor to sella nasion. Now, the normal value is around, can somebody guess it? I already told that it's around 102. Now, let's look at this patient sitting in front of us. Let's take a protractor. Those who are already joint focused, I have sent a PDF, and the PDF has a printout of all these x-rays. You can take a protractor, you can measure it if you want at this point of time. This is a learning process, guys. I would like you to learn and understand it in such a way that you'll never forget. This is all preparation towards an entrance exam, not just NEET. We are even looking at national boards. So look at it from a patient perspective. And this particular patient, the value is 103. Normal is 102. What is the value of this particular patient? 103. What does that mean? It's not a severe proclination. It's a normal proclination of upper central incisor, guys. It's a normal proclination. So what do you mean? The parents are lying to you? Parents are like lying, saying that my son's teeth is coming forward? Actually, that particular kid's upper central incisor is not forward. It's just normal. Now, let's look at mandibular incisor. Mandibular incisor from the, again, long axis, crown tip to root tip. Draw a line and the mandibular plane. Mandibular plane, there are many mandibular planes. We'll be explaining all that in our main program, different types of mandibular planes. But for explanation's sake, just take the bottom, the base of the mandible, the base of the mandible as your reference, and the long axis of the central incisor. How much should that angle be? Normally, that also has to be in the range of around 90 to 94, and this particular patient has something like 91, which means what? Mandibular teeth is also normal. It's not inside, it's not proclined, it's just normal. Upper teeth normal, lower teeth normal. You have a parent, father and mother sitting in front of you saying that my son's teeth coming forward. I see this every day in my practice, guys. I like to coordinate everything to my practice. I hate to have a separate curriculum for entrance people, separate curriculum for practitioners. I hate that. It's all the same. Father and mother sitting in front of me, telling that my son's teeth coming forward. And you just proved that teeth is not coming forward. George or anybody in the focus team, please disable the annotation. I am not the host to do that. Please disable the annotation. People are scratching on my x-rays out of hatred, out of boredom. I don't know. They're scratching on my x-rays. Please disable annotation, whoever the host is, please.
Yes,
okay.
Yes.
So this is the mandibular teeth normal. Now let's look at the normal value. I told you 91. It's all normal. Now let's talk about maxilla. Is the maxilla too forward? You're talking that way? Maxilla too forward. Okay. How do you determine whether the maxilla is forward? For that, we have something called as A point. A point is what? A point is nothing but that C-shaped curvature. C-shaped curvature from that alveolar crust. Look at the central incisor. Look at the alveolar crust. From the alveolar crust to the anterior nasal spine. Anterior nasal spine here is a C-shaped curvature. The deepest point of the C-shaped curvature is called as A point. A point means maxillary point. I wish somebody put that A point as MX point, maxillary point, but nobody did that. Dr. Steiner's way back in 1950s named it as 1940s, I have named it as A point. The point of the maxilla. That's the point of the maxilla. Now, let's look at sella nasion. I already covered sella nasion and to the A point. Sella nasion to the A point. For all those people who already got my PDF, the printouts are there. If you haven't got the PDF, contact me personally or Team Focus personally. They will send you the whole PDF. You can print it out. You can draw it. You can use a protractor. You can learn it. Guys, this is the only way to learn. Especially this topic, this is the only way to learn. That's why I put all those PDFs. Stellar nation and the nation to A point. The angle formed there, normal, has to be 82 degree. And this particular patient, wow, it's 83 degrees. It's normal. 1 degree is normal. Yeah. 2 to 4 degrees normal. So this particular patient maxilla is also normal. We found out that the maxillary teeth is normal. Mandibular teeth is normal. Maxilla is normal. Now let's come to mandible. Let's look at mandible. In the mandible, we are talking about something called as B point. B point. B is mandible. A maxilla, B mandible. So B is mandible. Mandibular point. Let's look at sella nation to mandibular point. That's a B point. Mandibular point, B point. The normal angle has to be 80 degree. So why is the sella nation such a big thing? Sella nation is such a big thing because that is the first area to ossify. Rest all needs more years to ossify. Growth gradient. Cephalocaudal growth gradient. All that will come in the growth and development class coming up hopefully next Sunday or the Sunday after that. I'm trying to simplify a topic called as growth gradient soon. Wait, it will come. But the cranial base, this area is supposed to fuse faster and first, and then the rest all can keep moving. So, in relation to the cranial plane, let's look at the mandible. Mandible means B point. Now let's look at this particular patient. In this particular patient, the mandibular point is only 71. Normal is 80. It's 71. So somebody already answered in the chat box. It's a mandibular deficiency case. You are damn right. It's a mandibular deficiency case. Nothing to do with upper teeth. Nothing to do with lower teeth. Nothing to do with maxilla. But something to do with mandible. Is this clear, guys? Those who are in the video, at least show me a thumbs up like this. Am I going right, guys? If it's boring, tell me. I can change the mode completely. Perfect. Dr. Sujay, Dr. Sara, you have said that I'm going okay. Dr. Anwar hasn't said anything. Dr. George has said thumbs up. Thank you so much. Yeah. Perfect. So we have a mandibular deficiency right here, proved here with cephalometrics. All you have to do is to put a twin block in. Complete myofunctional is coming in as a separate topic by myself soon. Wait. Bringing the mandible forward with a twin block. That's all you have to do. Nothing to do with upper teeth. Nothing to do with lower teeth. Bring the mandible forward with a twin block. And look at this guy. Look at that mendolabial sulcus here. Look at that mendolabial sulcus here. Look at that profile difference here just by bringing the mandible forward. But how did you diagnose? That is the importance of cephalometrics. So why do you need cephalometrics? Cephalometrics confirms your diagnosis between dental and skeletal. We cleared that there's no dental problem. We cleared that there's a skeletal problem. This kid, 6 months into twin block treatment, look at his jaw now. 6 months into twin block treatment, got his mandible forward. Now, if you look at the national board entrance exam perspective, you know what? You even improved his airway. Mandibular advancement devices, MAD, airway, sleep apnea. My God, so many questions are coming these days in NB part 2 in relation to this. You got his mandible forward. You got it forward to improve his profile, but you improved his lifestyle. You stopped his snoring. You improved his oxygen saturation. You helped him sleep better. National board guys, they look at all this. The questions can come anywhere around. So we just confirmed that this particular patient in front of me is a patient with a mandibular deficiency, got the mandible forward. So what is lateral cephalogram? Lateral cephalogram is a study of a lateral ceph. Come on, obviously, study of a lateral ceph is called lateral cephalogram. Way back in 1931, Hofrath and Broadbent, again, questions coming in NEET, AIMS, and even National Board. Proponents of lateral cephalogram, 1931, Hofrath and Broadbent. When you hear that Hofrath and Broadbent, the immediate thinking will be like these people sat together and came out with this concept. No. This is one of the most interesting things that happened in orthodontics. In 1931, Hofrath in Germany, Broadbent in America came out with articles together. See, I'm just telling all this to make sure you remember all this. Questions can come anyway in your entrance. They never work together. It's not like McLaughlin and Bennett and all that. No, it's not a together work. It just came together, coincidence. It came together. Hofrath in Germany and Broadbent in America came together same year. And they are both accepted as the pioneers in lateral cephalogram studies. So I have seen even questions asked, who are the proponents of lateral cephalogram studies? 1931. I even saw a question asking the year. It's ridiculous asking the year, but I saw a question there in one of the NB questions, which year? That's 1931. So that's why I wanted to cover that quickly. All this lateral cephalograms taking using a cephalostat. When you come to a cephalostat, that's very interesting again. You have the X-ray here. You have the X-ray here. Look at my mouse. You have the X-ray here. You have the patient standing here. That's the mid-sagittal here. And this is the X-ray film. This is a film or the digital sensor, whatever. This is a film or the sensor. So this is a cephalostat. You know what? I've even seen questions being asked on how much is the focal length of this X-ray source. How much is that? 60 inch, 5 feet, 5 feet. I've seen questions on that also on national boards and even NEET. Last year NEET, I think this came, 60 inch. But the point I'm trying to cover here is all over the world, you take your kid for a lateral cephalogram X-ray. It's a universal phenomenon going on. That is, it is a 60-inch distance from the mid-sagittal plane and another 15-inch as the cassette, the film or the digital sensor, whatever it is. I've seen questions, how much is the focal length of the X-ray source? Watch out. But what I'm trying to cover here is, this is universal. X-ray taken in New York University at this point of time. Why I said New York University is because I was trained from New York University. So the X-ray taken at New York University and in Alua, where I'm working in at this point of time, but you do a lateral ceph tracing, the angulations will be exactly the same because Everywhere in the world, it follows this philosophy. So look at that distance, note it down. All that will be clearly covered in the coming year, big sessions on all this. Do not worry. These are orientation programs going on. Do not forget there is something called as frontal cephalometry also. Heard about that? Lateral cephalogram is so famous. Have you heard about frontal cephalogram? That's also important. Frontal cephalogram is like front view, AP view, anterior posterior view. This. So what is it trying to understand, trying to explain here? It's trying to explain the width, the transverse width, the midline asymmetries. This side this much, this side less, this side more. The midline discrepancies. For that, there are analysis on frontal cephalometry also. I recently saw a question in National Board again on frontal cephalometry. That's why I decided to put this particular slide. Quickly into landmarks. Landmarks, I'm sure many of you are pretty much familiar about these landmarks. Let's look at nasion. What is nasion? Nasion is nothing but the frontal bone meeting with the nasal bone. That point where the frontal bone meets with the nasal bone is called as nasion. Sella, the midpoint of the pituitary fossa. Look at the pituitary fossa here. If you assume this pituitary fossa as a circle, and the midpoint of the pituitary fossa is called as sella. A point, I think I already told about A point. A point is the curvature, deepest point on the curvature, C-shaped curvature formed from the alveolar crest to the anterior nasal spine. The C-shaped curvature, the deepest point, A point. A point represents maxilla. B point represents mandible. Deepest point from the alveolar crest to the mandibular symphysis here. Look at that. The highest point here, alveolar crest, the C-shaped curvature, deepest point is the B point. Now, what is this? This is external auditory meatus. External auditory meatus, the topmost point, superior point of the external auditory meatus, called as the porion, P or PO. It's called as P or PO. And then orbital. What is orbital? Orbital is nothing but the most inferior point of the bony orbit. This is the orbit. The most inferior point here is the bony orbit of the bony orbit is the orbital. O, point O or OR. Some people call it OR. Let's look at mandible a little more closer. In the mandible, come on, come to the chat box and tell me what is this point. Come to the chat box and tell me what is this point. This is just to make sure nobody is sleeping here. Come to the chat box quickly and tell me what is this point. B point. Perfect. Everybody knows that. Good. Now, what is this point? The most superior point. The most superior point of the mandibular symphysis is called as the pogonion or the POG. And the most inferior point, inferior-most point, below that there is no bone, is called as the menton. Once you get the pogonion and you get the menton, in between these two, arbitrarily, in between these two is called as the nasion. I've seen even questions in National Board. Name the constructed point out of the following. Name the constructed point out of the following. And the answer A, B, the B point. B point is not constructed. You know where is B point. Pogonion, you know where is pogonion. The most superior point. Menton, you know the most inferior point. So GN, nation, is actually a constructed point according to cephalometric theory. It's not a natural point. It's a constructed point, which is a midpoint of the gonion and menton. Guys, questions can come this way also. And then comes gonion. Gonion is another constructed point. Base of the mandible, you draw a line. Ramus of the mandible, you draw a line. And then it meets at one point and put it on to your mandible. And that point where the base of the mandible meets with the ramus of the mandible is called as gonion, which is again a constructed point because you just constructed it. So I've seen even questions being asked, which of among the following is a constructed point and a natural point? Questions can come any way you want, guys. Okay, let me take up some questions here. I'm almost done, guys. I'm almost done. Let me take up some questions quickly. The conjunction of the frontonasal suture. Can somebody come to the chat box and type in the answer before I put the answers here? Bregma. Interesting. Learning too much. That's the problem. Some people learn too much. Conjunction of the frontonasal suture. According to this was from national boards again. Yeah, this is the place where the frontal bone meets the nasal bone, and that's called nasal. It's not frontal. Come on, it cannot be called as frontal. It cannot be called as sella. Sella has nothing to do with it. Nasal, no. Very confusing. Cannot be called as nasal. Basion has nothing to do with it. Basion is way back in the foramen magnum area. And then the answer obviously is nasion. Yogida answered it correctly. Conjunction of the frontonasal suture. Can I go to the next question? I'm almost done, guys. I'm trying to answer some questions here quickly. Question number 2. Anterior point of the frontonasal suture. Actually, it's the same question asked in multiple entrants in different ways. It's the same thing. End of the day, it's the same thing. A point? No, come on. It cannot be A point. B point? No, it cannot be a B point. It cannot be S point, that's sella. So the answer is N point, nasion, what we just covered in the previous question. Deepest point, come to the chat box, guys. Deepest point on the concavity of the mandibular profile. Deepest point on the concavity of the mandibular profile between the point of chin and the alveolar crest. Sujay Singh just said A. Are you serious, Dr. Sujay? Mandibular profile. Mandible is B. Mandible is never A. A is maxilla, Dr. Sujay. Are you here? Are you listening to me, Dr. Sujay? Show me a thumbs up. I can see you. Do you understand what I mean? No. Okay, perfect. Mandible is B. Maxilla is A. So, obviously, the deepest point here will be the B point. Answer is no. A point, no. N point, nasion, no way. S point, sella, no way. And the answer, obviously, is the B point. You got it there. Now, the deepest point of the maxillary profile between anterior nasal spine and the alveolar crest. We covered all that, guys. This is simple, but these are multiple ways they can put up the question. Once you get the concept that the maxilla means A point, mandible means B point, things are very easy. Let's look at that. These are the answers, and that's the correct answer. We've done that. The most posterior inferior point of the angle of the mandible. Listen carefully, guys. Do not answer immediately. The most posterior inferior point of the angle of the mandible. Before I put the choices, oh wow, Shubham already answered. Going on. Perfect, perfect. So you know that is the base of the mandible, angle of the mandible, posterior, inferior has to be gonion point. Perfect. You got that. Lowermost point of the mandibular symphysis. Very, very common questions. I'm going against my concept of 15 by 5. I'm going by 15 by 10. I'm trying to cover 10 questions quickly because this is such a topic where so many questions can keep coming on this. Yeah. So that's a B point, PO, POG. No, it's a MENDON or ME. Many people already answered that. Thank you very much on that. Most anterior point of the bony chin. So many variations can come. Most anterior point of the bony chin. Anybody wants to type that? Menton, no. Sujay Singh, Menton again. No, it's Pagonion. Yeah, it's Pagonion. It has to be not Menton, not B point, not A point. It has to be Pagonion point. POG, not PO, POG, which is Pagonion, which is the most anterior point of the mandibular symphysis. Highest point on the bony external auditory meatus. External auditory meatus. And the highest point. Actually, I talked about it a little when I talked about something. Yeah. People got it. It's not OR. OR is orbit. BA is Basion, way back in the foramen magnum. S point, it's Cella. So the answer has to be PO or P, which is called as Porion. Perfect. Perfect. You guys got it. Frontal cephalogram is used for. Frontal cephalogram. I think I talked a little about it. Frontal cephalogram is used for overjet. No. Overjet means lateral cephalogram again. Dental compensation in sagittal plane. Sagittal. Guys, those who are not very familiar with these terminologies called sagittal, let me tell you one simple point here. Sagittal side. S side. Sagittal side. Side. Side means lateral cephalogram. Sagittal. Side view. S. Letter S is sagittal, is side. So lateral cephalogram is sagittal. Frontal cephalogram cannot talk about dental combination or compensation sagittal. No, sagittal is side. Frontal cannot talk about side. Okay, S, capital S, sagittal is side. Deep bite, again vertical. Vertical also, from the side only you will understand. Open bite, again from the side only you will understand. So the answer obviously has to be to assess the facial asymmetry, the sideways, the transverse, from the front view, the transverse, expansions, unilateral expansion, bilateral expansion, all that expansions is what we are talking about when we are talking about frontal cephalogram. SNA indicates, come to the chat box, come quickly. SNA indicates what? Cella nasion to the A point. But what does that indicate? Relationship of the mandible to the cranial base. No. A point. The A point here means maxilla. Nothing to do with mandible. So not mandible to cranial base. The relationship of the mandible to the palatal plane. Again, not mandible. So you can, this is from National Board again. You can forget that mandible. The moment you see mandible, A point has nothing to do with mandible. So leave it. What is the next question? Next answer. Relationship of the maxilla. Yeah, listen carefully. Relationship of the maxilla to the Frankfurt horizontal. That's important here. Frankfurt horizontal is from the porion to the orbitary. Porion, I told you, the external auditory meatus to the orbitary. Frankfurt horizontal. But SNA is Cella nasion. Cella nasion is cranial base, not Frankfurt horizontal. So the answer is a relationship of the maxilla to the cranial base. One more question done there. Lastly, I'm going to wind up this session with one last patient of mine, very favorite patient of mine, with a severe mandibular prognatism. Look at the X-ray. Look at the X-ray. Look at the cella nasion and nasion to B point. Cella nasion and nasion to B point. That is S and B. What is the normal value of S and B? Can somebody come to chat box and tell me what is the normal value of S and B? I already covered that point. Normal value of S and 80. Perfect. Perfect. No, Rahmat, not 90. 80. Yeah. And look at this particular patient. It's 89. A definite increase in the mandibular positioning. Definite increase in the mandibular positioning. 89 degree. What do you call as a typical class 3. So all you have to do in this patient is a 25-year-old female. 25-year-old female with a class 3. All you have to do is to go for a orthodontic surgery. Get that 9 degree down to 80 degree. 89 to 80 degree with orthodontic surgery. I'll be covering a separate topic completely on orthodontic surgery, pre-surgical orthodontics, post-surgical orthodontics, decompensation. All that will come soon in our main classes. This is just an orientation class, guys. But what I'm trying to prove here is team focus is united. We are on 10 to 12 faculties, all united, ready to teach you from basics. Then get the concepts clear. Once the concepts are clear, questions can be easily answered, guys. Get the concepts cleared. So with that surgery, you can change this patient's face completely. Give her a better life. Give her a better profile and a better life. So this is it. Cephalometrics, one of the most boring topics. All I wanted to tell you here is to simplify it with patient perspective. All the 1 hour, 2 hour programs coming up for our main program is all going to be like this. And interestingly, all our 12 faculties are together on this. Guys, this is only one group in the whole of India, I would say, together with staff meeting happening every night at 9:30 p.m. Believe it or not, night at 9:30. Within 30 minutes, we have a staff meeting. How to improvise, how to get candidates more knowledge on not just NEET, national boards, Australian Dental Council, Canadian, New Zealand, whatever. Concept has to be conveyed. Without getting concepts cleared, there is no way you can answer MCQs. 15 by 5 concept, but that 5, tonight I changed that 5 to 10. Thank you very